Here are the 5 main scenarios, and we'll start with peritonism, muscular defense, rock-hard abdomen, and pain on abdominal percussion. And we always look at this the same way: clinic, diagnostics, diagnosis, and therapy. And if this classic triad is presented, the muscular defense, the hard abdomen, and pain on percussion of the abdomen, then one suspected diagnosis is gastrointestinal hollow organ perforation. In the lab works, of course, we see leukocytosis with CRP elevation, and on X-ray, we see free intra-abdominal air under both diaphragmatic domes. Normally, you would order an abdominal X-ray, but you can also beautifully see how the air is located under both DOMs in this chest X-ray. If necessary, you can then do a computed tomography scan to get an idea of the location of the perforation, if you haven't already found that clinically. It is possible that in the case of a gastric ulcer, the symptoms have their point of maximal intensity in the upper abdomen, and in the case of a perforated sigmoid diverticulitis, the pain is found in the left lower abdomen. However, in the maximal form of acute abdomen, there will be no differences, and pain is everywhere, so that it may not be detected clinically. Therapy is usually always an explorative laparotomy. In exceptional cases, for example, in a perforated ulcer, one can try to treat it minimally invasive with explorative laparoscopy. How urgent are these cases? These cases are usually reported as none 1 category operation within 6 hours. But of course, you will still try to get into the operating room as quickly as possible. It often takes less than an hour to get to the operating room with such an acute abdomen. Therapy consists of exploration, lavage, focused sanitation, and drainage. Now let's look at an example.